Gavin has asked me to talk about the economics of blood management. Here's my disclosure of conflicts of interest. The more you have, the more independent you are. I took the freedom of a title change from the economics of blood to the exceptional mismanagement of health funds in the blood sector. Here's the overall picture. This is the healthcare expenditures relative to the gross domestic product for the last some decades. And you can see that in most countries by 2050, health will attribute about 20% of GDP. And in the United States, more than 30%. And the question is really who's going to finance this burden. Now let's start with a few provocative statements. First of all, the hemovigilance problem. I think it's a bottomless pit. Here's just an example to show you how extreme the precautionary principle is. Just to keep the blood pool clean from Hep C and HIV, we spend about $5.8 to $8.4 million per QALY just for this test assay. If we compare this to the threshold of public health policy decision-making of $50,000 per QALY, just this test alone exceeds it by more than 100 times. And so we know the cost of the inherent transfusion risk is immensely high, but for this cost you get at least a blood pool which is safe of HIV and hepatitis. But there are other emerging infectious agents, and they're here grouped by several levels of severity, and I think it's a lot, isn't it? Now, there is an example of how costly this fear is. In Australia, there was a suspicion of dengue in the blood pool in 2009, and so they discarded about 7% of the nation's entire blood supply. Or here's some very interesting new evidence with a group around Claudio De Soto. He's one of the world's leading prion researchers. The question arose whether there is Alzheimer's disease in the blood. And this has been proven by a transgenic mouse model where human Alzheimer's disease has been injected into the mice, and the disease has been propagated in these mice. And now there is some research underway to find out whether neurodegenerative diseases might be transmitted by blood. And of course, the media got wind of this already. Then here's what we call the health production curve, and I'm questioning the word health in it. What you see here on the y-axis is health benefits and QALYs, and here's the total cost. And we look here at blood test assays, and you can see that some very basic assays, they're quite cost effective. But when we get down or up here to things like pathogen inactivation, you add an enormous amount of cost with a very little effect on QALYs, on quality adjusted life years. So pathogen inactivation is estimated to cost about $11 million per QALY. So, and this is a cost not to fix health, it's just to make the product a bit more safe. It doesn't say anything about the outcome. Therefore, I think it's quite misleading to use this in this publication as a health production curve. Here's some comments from blood bankers. Each QALY of further blood safety measures costs far more than it does in any other sector of healthcare. And Brian McClellan from the Scottish Blood Service simply asked the questions, have we lost the plot? Brian Custer says blood safety interventions could be said to be stealing monetary resources from health interventions that would generate more health in the population elsewhere. So next provocative question is, do we turn a blind eye on the demographics? Here's the impact of the aging population on the blood supply, and it shows you basically the relation between the population non-donating divided by the population donating multiplied with 100. And you can see over the last 20 years it has been incrementally easier to source an additional unit of blood. But because the first baby boomer turned 65 on January 1st, 2011, the curve is now reversing, and you see here, this is for you, Marco, this is Italy, 65% as the total transfusion dependency ratio in the near future in Italy, for instance. And it's much worse on the demand side. That was the supply side, but here's the demand side. This paper by Akif Ali shows that the segment of the 70 and 80-year-old patients, which is basically your patients, have an 8-fold higher RBC consumption than the younger age segments. And you can see here from the neonates to the 100 years of age patients and the utilization by 1,000 population, that it's really happening here. And this is the segment which is going to double in the next 10 to 20 or 15 years. We did a extrapolation for Australia, and it shows you that by 2040 we would have a shortfall of almost 500,000 red blood cells, where we currently use about 800,000. So this is really a very dynamic effect. The next question is, are we squandering resources? When you look into transfusion data and you compare it by countries, like here, Australia, Europe, United States, why do the Danes, we call them the bloody Vikings, use about 60 per 1,000 population, and the United Kingdom just about 40 or 38, and currently in Western Australia 28? When you do it by match patients and, let's say, elective surgery, CABG or hips or knees, and you look at the transfusion variability between centers, you find ranges of 1 to 17, which we recently found in a large study in Austria. And when you look at the ranges per doctor, this is what we do now in a continuous benchmark in Western Australia. Patients in RBC units per surgeon performing elective CABG. I've blinded the patient identities, but these are the hospitals. You have some guys who operate on 65 patients in primary CABG and use 36 units as total numbers. You have other guys who operate on 36 patients and use 89 units. So you really see this huge variability across countries, across institutions, and between colleagues. Are we accounting with blurred numbers is the next question. Everybody says blood's basically free, it's freely donated, but it doesn't mean that transfusion doesn't cost anything. We did a study on 4 centers, 2 in the US and 2 in Europe. These are the costs of 1 unit of red cells in US dollars, about $250, let's say. But this is the activity-based cost of getting 1 unit into the veins of a patient, which involves all the testing and the nursing time and the monitoring and the managing of acute transfusion reactions, etc. And then, of course, you've got to multiply these activity-based costs per unit transfused with the actual number given to a surgical patient during his stay in the hospital, and then you end up between $3,500 to $2,000 per patient. The next question is, blood products, do we get real value for money? What you see here is a cytoscan. I mean, it's not a study, but it's a very interesting wake-up call, I might say. A cytoscan with a high-density light on the microscope under the tongue. And this patient had a hemoglobin level of 2.8 grams per deciliter. He had an ulcer bleed. And what you see here is, oops, sorry. David, you told me how to run this. I'm a Mac person, and this is a computer. I'm sorry. So you see this patient, he is resuscitated, and you can see that the few red cells he has, these are the large ones are multi-cell capillaries, these are single-cell capillaries. I mean, there is perfusion. And it works. Can you do this the next as well, please? Next one, too? Yes. Now, then this patient gets a 3-unit transfusion, and look at the same capillaries. What you see is a blockage. You see a total change in the architecture. You see a sludging effect. So it's quite interesting what's happening here. And that in California and UCSD, we do more research in animal models now to see what is the impact of fresh blood, of old blood. What's the impact of transfusion after an hour, after hours, after days, etc. And if you look at the different qualities, the maximum storage time of 42 days versus ultra-fresh blood, this is your slide, Gavin, you can see really you pay the same price for very different qualities. I mean, you wouldn't do this for a used car and a brand new Porsche, but you can see here we don't differentiate, and there are some, depending on the location and the proximity to the blood center, whether you get older blood or fresher blood and other questions. And of course, within the blood bag, there's a lot of in vitro changes which might have a lot of post-transfusion impacts, and there's a lot of research still to be done. So based on all this, what are sorry, that was the wrong slide. The next question is about the outcome, and this is something Marco Ranucci will handle. But this very broad statement here, there are few, if any, articles that support transfusion actually improves patient outcomes. The majority of database papers shows associations between transfusion utilization and with immunosuppression, increased infection, increased renal failure, MOF, and death. And here's what we summarized across about 500 different studies, including almost 3 million patients. What are the reported adverse outcome? And it reaches from infection, septicemia, to myocardial infarction, all sorts of ischemic events, of course, increased mortality, and then all the economic implications with increased length of stay at the ICU, on the ward, readmissions, etc. Here's a paper from the group around John Morton in Stanford, and they looked into the Medicare database of 39 million patients, quite a cohort. 2.3 million of those have been transfused, and after adjusting for age, gender, comorbidities, admission type, and DRG, transfusion was associated with a 1.7 increased odds of death, 2.5 days longer lengths of stay, or about $17,000 higher charges. Now, if you add this up, there's about $40 billion of additional burden to the system. If you add the activity-based costing of transfusion, as I've shown you before in these cost studies we conducted, then you end up with 50 to 60 millions just for red cells and just in the United States. There's a question, of course, how much of this is causative and how much is associative. But the fact is, we are talking about big numbers. The prescription drug volume in the same year in the United States was about 250 billion. So we are not talking marginal costs. So what is the overall conclusion? I think it's a mess. And the incremental cost effectiveness ratio is basically the formula to compare the cost of two different interventions and the effectiveness, which is done in all pharmaceuticals, but it's rarely done on blood components, if at all. So what we can see, the cost of transfusion is increasingly expensive, because of this gap between demand and supply, and whenever a product gets scarce, then the prices go up, of course, with a lot of unintended adverse outcome. And if we do a critical comparison in the world of medicines and medical devices, according to EMA and the FDA, you have to look at quality, safety, efficacy, and then you do your cost and cost effectiveness analysis. But this is very limited when it comes to blood products, and when you look at cost effectiveness, is basically absent. So maintaining the clinical status quo as a transfusion practice would not be accepted or tolerated in any other field of medicine in the context of current safety and quality standards. So where to go from here? Well, the World Health Organization has adopted by the resolution WHA 6312 in May 2010, and said, bearing in mind that patient blood management the patient's own blood rather than resorting to donor blood, means that before surgery, every reasonable measure should be taken to optimize the patient's own blood, to minimize blood loss, and to harness and optimize the physiological tolerance of anemia. And it's referred to in that resolution as the 3 pillars of patient blood management. Patient blood management preempts and significantly reduces the resort to transfusion by addressing modifiable risk factors that may result in transfusion long before transfusion may even be considered. And we have this triad of independent risk factors, which is blood loss, bleeding, anemia, and transfusion. Of course, there's a vicious cycle around this, but they are modifiable. You don't need to accept them as they are. Anemia can be undone by optimization of red cell masses with pre-op anesthesia clinics, for instance. There's a lot of modalities out there to minimize and control bleeding, and you can also harness and optimize physiological reserve of anemia. And this also includes that you get over the 2-unit transfusion policy. Just use one instead of two, and reassess the patient. And this is, of course, in a multidisciplinary team approach. When you split it by the pre, intra, and post-op phase, then you get a 9-field matrix. I don't want to go into the detail, but all the modalities are basically in there. And the term patient blood management becomes more and more mainstream in various journals. And in Australia, we have now started to develop patient blood management guidelines instead of transfusion guidelines. The term transfusion guidelines doesn't exist anymore. In the introduction, you see again these 3 pillars. We have now just recently, you can pull this from the web, the perioperative guidelines, and there are 4 other modules coming out very soon. We also have a transfusion patient blood management program in Western Australia. Here you see the per capita transfusion per 1,000 population across Australia. And in Western Australia, we started our program. We are down now to, this year we're down to 2601 per 1,000. That's about half of the European average. And my last slide, this is my friend and your colleague Mani Estioko, a cardiac surgeon, a cardiothoracic surgeon in the United States. And his standard is 0 red cells, 0 platelets, 0 FFP. And he does this not only in let's say primary cabbage, but also in very complex procedures. Thank you for your attention. Questions?
Hi, Will Lester here. I'm a haematologist. I mean, the outrageous spend on blood safety. I mean, my thought, and I think a lot of people share this thought, is it's probably relating to what happened to that poor French fellow who got imprisoned for allegedly introducing HIV testing a bit too late for blood products. It seems as if no one is prepared to take the responsibility of saying no more extra tests on blood products because no one wants to end up in prison. And so it seems that we can spend outrageous amounts of money and yet deprive the rest of the health economy. I mean, I don't know if you have any comments on that.
Yeah.
As to why you think, you know.
Yeah, I think the problem with blood is emotionally charged. And it's all a political decision. It's not a clinical or medical approach to this whole problem. Fact is, you have, as a private person, you have, unless you're not a Warren Buffett, you have a limited budget. And you can spend your euro or pound just once. And if we see the enormous amount spent per quality for blood safety measures, we clearly know that we cannibalize other sectors at a very high rate. And this is just a fact. And I think what we need is a very sober discussion about how do we allocate limited resources of public funds.
Axel, Ravi Gill from Southampton. Thank you for a stimulating talk. I like the concept of patient blood management because I think it's better than transfusion guidelines. I think that we don't look after patients' own blood well enough. More importantly, I like your pillars. I think that the most important thing is we've got to make sure patients don't come to the theatre anemic.
Anemic, exactly.
However, at the far end of your patient blood management is where I think we will see some controversy as time goes on. Because at the moment, all the observational data says don't transfuse, people will tolerate anemia. But we don't really know the answer to that question yet. Gavin's Title II study, some of the age of blood studies that are being, the RCTs that are being done, may give us those answers. And I genuinely hope they say we can tolerate anemia. But if they don't, and they say, actually, we need to transfuse, how are you going to manage that in the patient blood management system?
Yeah, good question. All these discussions around the trigger are basically somewhere on the right pillar, and what I think is the beauty of patient blood management is the preemptive factor. As you said, make sure that we don't have anemic patients going to theater. For instance, we just did a study in Austria with Hans Gombots in Linz, and we know from the Austrian benchmark studies published in Transfusion that the anemic patients, which they have a prevalence in I think in cardiothoracic surgery of 20%, is that probably correct, 24%? But these 24% of the anemic patients take up to 70% of the blood supply. So why don't we fix them prior to surgery? Even if we have very little time left, between we see the patient first and we operate on him. There was a recent study in anesthesiology, just a small RCT, showing that even on the day of surgery, you start with iron administration, IVR, and you reduce the transfusion requirements by 50%. So there's a big chunk, and this is where we had the early wins in the Western Australian program, that we looked at the anemic patients. That's a leverage point. Then when you come to point of care testing as the middle pillar, given that cell salvage and all these other things are in place anyway, you have another gain. And of course, what I say is doing nothing is the worst, transfusing is the second worst, patient blood management is a bit better.